As Dr. Gibson said, welcome. We're so glad you're here this morning for our ABIN monthly webinar. We're going to go ahead and get started so we make the best use of our time this morning. It is a great honor for me this morning to introduce Dr. Alexander Blount. I've had the great privilege of personally attending some trainings with him in 2009 when I was first getting started on my integration journey. So now I'm going to tell you a little bit about Dr. Blount. Dr. Blount is a professor emeritus of family medicine at the University of Massachusetts Medical School, where he founded the Center for Integrated Primary Care. His online training program in primary care behavioral health at the center has trained over 4,000 clinicians around the country and abroad. He has written several books, including Integrated Primary Care, The Future of Medical and Mental Health Collaboration, and Patient-Centered Care, Getting from Good to Great. He is the past editor of Family Systems and Health, published by the APA, and past president of the Collaborative for Family Health Care Association, or CFHA. He spends the majority of his work time providing consultation and training in behavioral health integration and patient-centered care. And his work, and he also included a link that I sent out with this bio, so you can look at some of the work that he has done. He also has done some work recently in telehealth and has a telehealth video that's also included with the information that I sent out. In saying that, we would like to ask this morning that we have Dr. Blount's presentation, and then, as Dr. Gibson said, you could put questions in the chat, but we would like to hold questions to the last probably 15 minutes of our time this morning, and this will give us an opportunity to listen to Dr. Blount and have him give the information to us. So without further ado, Dr. Blount, we're going to turn it over to you, and we're so excited you're here this morning.
Thank you very much, Kim. I really appreciate it, and I appreciate this opportunity. I want to start, before I go to my slides, to take just a moment to recognize and honor this as Veterans Day. I find this very much on my mind these days. My father, who was a World War II veteran, passed away this year at the age of 102. He was at the battles of Okinawa and Iwo Jima in the Pacific. And at one point, his ship was hit by a kamikaze and they abandoned ship. And he was in the water for a number of hours before he was picked up. And it took the Navy about 2 weeks to find him officially. So even though he had been safe after a few hours, my mother for 2 weeks thought he was lost at sea. And during that time, I was born. And so they had plans to name me something else, but that's why I'm Frederick Alexander Blount, Jr. Because she, at the time, thought he wasn't coming back. And so it's something that when Veterans Day comes around is very much on my mind. Okay, let's go to sharing screens and looking at slides. And okay, that should be right. You should be seeing it, seeing the slide. And if you're not, or if there's a problem, Kim, please break in and tell me. So let's start with a sort of general understanding about how important our topic is. Behavioral health integration is crucial to population health, I want to assert, and for a few reasons that I'll give. One is that health outcomes generally, that means how your likelihood of having a chronic disease, the likelihood of behavioral or medical morbidity, quality of life ratings, birth outcomes, life expectancy, in other words, the things that make a difference to people medically and behaviorally all correlate with income inversely. So we are talking at this top about the less advantaged folks being the greatest number of the folks we're needing to serve with behavioral health integration. Oops, come on back up. Oh. The vast majority of behavioral health needs, the people with those needs, won't accept a referral to specialty mental health or substance use care.
$99 a year right now.
Someone who just said $99 a year has their mic open and needs to mute.
I'm going to go ahead and mute all.
Okay. So the folks who have the most needs are least likely to go to specialty care if it's there. In many places, it's not there, or it's full, it's completely loaded. But it means that for those folks, that service in primary care is the only possibility of access, of making access. And so when you think about this, think about the fact that people are less likely to use behavioral health services, even though they have the most needs. It is it's a function of the kind of stigma about behavioral health or mental health or substance use issues that many people have within themselves, not about stigmatizing others, but just the idea that, oh, it's in my head. Oh, you think it's not, this is not real, or this is something that is a character flaw. That kind of stigma we have access to overcoming in primary care and nowhere else. And so moving behavioral health services into primary care is the single most effective approach to reducing stigma around access and offering equity in care. And this is even more true in relation to minority populations. This is Surgeon General Satcher, whose report on culture, race, ethnicity, and mental health said, among other things, that racial and ethnic minorities are less inclined than whites to seek treatment from mental health specialists. Indeed, instead, studies indicate that minorities turn more to primary care. So moving behavioral health, mental health, substance use services into primary care is crucial for equity, both in terms of racial groups and in terms of income. So and this is a penny that has dropped in come on back. Folks, I don't know what's going on here. Let me go down here. There you go. I have too heavy a touch on the touchpad, and I just lose control of my slides sometimes. So we're talking nationally now, mostly about getting from the why to the how for integration. And by the way, I looked up the webinars, the series that the Arkansas Behavioral Health Integration Network has online, and you have had some really good folks talking in this series, some of the best. So the issue of, or the evidence around why do this is available and clear. There's also strong evidence of overall cost reduction in mature programs, meaning not right at the top, at the front. There's clear evidence of better patient satisfaction and improved quality of life. There's clear evidence of improved provider satisfaction and reduced burnout in the presence of high-functioning clinical teams. In other words, I mean, you know, what does it cost to replace a physician? 300,000, 400,000? You lose one doctor and you've cost yourself so much money. And the evidence that doctors are happier about their work when they feel they can adequately serve their patients. The thing that tends to drive them away is feeling like, I just can't help these people. And behavioral health issues in primary care that can't be addressed with a prescription are a big piece of folks getting that kind of feeling. But it's important to be clear that when you do this, when you start to use it, introduce behavioral health integration, it introduces uncertainty. It will impact the workflows, it will impact billing issues, it will impact how people understand their work and what the team is. So for each site considering integrating, why has to be addressed again. This is not something that is addressed at high levels. This is why we're doing it, and we're going to go ahead. There's going to be a need at each practice level to bring the idea of why we're doing this into a conversation. One thing that people tend to, the people who are sort of saying, let's go forward with integration, it is possible to begin to act like integration is the goal. Integration is the thing we want. And you have to keep going back to the idea that better patient care is what we want. Integration is a way of getting it, but we're always interested in better patient care because that's why we're all here. And so at this minute, you know, I've been to a lot of organization workshops, and they always talk about how the Chinese characters for crisis is a combination of danger and opportunity. And that, in fact, is not the case. Because Americans understand opportunity as, oh, we're going to get something great. No, the Chinese sinograph actually for crisis is a combination of danger and the crucial point when something begins to change. And it can change in multiple ways, potentially. So what we're saying, this is a crisis in healthcare. It's a crisis around the pandemic. It's a crisis around workforce issues and the stress on the workforce. It's a crisis around healthcare equity, all of those issues. And so it is a point when something will change and things will begin to be different. But in what direction, we have to decide. So where do you start? Well, I would suggest, and this is just me, that you start out by being clear on why you're doing it. That because you're going to have to talk about why you're doing it over and over again. The important part of the mission of serving your patients, yes, you'll keep coming back to that, and I'll come back to it again. But in a particular practice, it might be because you have a subgroup of patients with a particular need. Complex burdens of illness, high cost. Sometimes these folks are called high utilizers. They also happen statistically to be underprivileged folks, disadvantaged folks, and to have high rates of trauma. Or maybe you say we have a population of opioid users and we don't know what to do. And we're going to do medically assisted treatment, but there are all kinds of behavioral needs in relation to medically assisted treatment. Think of the impact on families and on the patient when they get sober, and how the roles change and all of the distrust. There is a great deal of behavioral health work to do with successful MAT programs. Presenting multiple somatic symptoms, that's another group that drives providers. I was going to say batty, but no, the idea of the physicians I know being batty just doesn't go together, but makes them very frustrated. Let's put it that way. These folks come back, and if you refer them to a mental health center, they will not go. They'll say, you think it's all in my head. On the other hand, when there was a recent article that just came out that said that the outcome using the PHQ-9, which is a rating of depression, as an outcome measure wasn't really viable, that it didn't work as an outcome measure because it wasn't reliable over long periods of time. On the other hand, the measure that was a better correlation of improvement for depression was reduction in somatic symptoms. Assist stressed PCPs. They are struggling, and they're struggling because of the pandemic, and they're struggling because of what they have to do anyway, and because the populations they're seeing are sicker. And so adding behavioral health is another reason you might do it. Another is that maybe you're screening people because it's required, but part of the requirement for screening is you have to have a treatment option. Now I'm blocking on the name of the organization that highlights what the evidence is on screening. Preventive Services Task Force says explicitly, don't screen if there's nothing you can do with a positive screen, if you don't have some option for what to do. So you're going to get better payment sometimes for screening. You're required to do it. You need to have an option. Or once in a while, it's just because you have a behavioral health clinician who's available and interested. There's been a lot of programs that started as in just that way. But what you're going to need if you really want to have integration is it's going to require the leadership to be on board. That the leadership is going to have to come back over and over saying, yes, this is part of our mission, whether the mission is whole person care or population health or health equity. It's easy to make the case that integration is crucial to that mission, but we're going to need to keep saying it. It helps a great deal to have identified a physician champion in any setting, that it is a fact of the medical world that many disciplines have something they want to say about how physicians ought to do. And physicians are more receptive to suggestions from other physicians. And so whenever you have a new behavioral health person in a practice, one or two or three physicians will start referring, start involving them, think this is really great. Other people might be very hesitant. I'm handling my own patients, thank you very much. Or I don't really know what this person does. Or why are we talking about this? It just takes up more time and I don't have any time. Having a physician who says, let me tell you how this helps. Let me tell you what these folks can do. Makes a great deal of difference for the evolution of the program. You want to have substantial onboarding and in-service training for new BHCs. They come out of training in specialty mental health, not quite ready to serve in primary care. Specialty mental health is one way of doing behavioral health and involving treating people for longer periods of time, treating them for an hour. In other words, limiting the number of people you can serve and serving them in a longer way. Whereas in primary care, access is really crucial. And because you're seeing people earlier in the development of symptoms or problems, it takes less time to make the same level of difference. And we want to serve the whole population. And so those folks, those new behavioral health integration folks, BHCs, behavioral health clinicians, are going to need some training and some leadership in order to be able to do it. And excuse me, and there is a whole history of failed programs or programs who didn't do that, who just let the mental health folks come in and do what they do in specialty care. And it won't work. They'll back up, they'll have an internal waiting list, the docs are going to be frustrated. It's not going to work. So you need a designated leader for the behavioral health effort in anything other than just one practice. And you need someone with experience in integrated settings, not someone who has been supervising somewhere else in the field. That won't help. If you're going to treat, you should treat BHCs as providers in the sense that they provide care in the same way that medical folks provide care. And that is different from treating them as staff. If you want to hold on to the workforce as they become more and more central to the effort in a practice, they need that kind of respect. And there are lots of ways that organizations show that kind of respect. And the other thing is you need the behavioral health perspective, not just the service. And so you have a lot of meetings that are going on that we think of as medical. You know, we're talking about chronic illness. Why would we have the behavioral health clinician here? We're talking about chronic illness. No, the behavioral health perspectives, what you're missing, and particularly what you're missing in the situations where it's not improving, where things aren't getting any better. Will it pay for itself? That's another sort of ways that people often start. Well, is it going to pay for itself? So let's be realistic. My answer is probably eventually, but you should settle in for the longer haul. Here are some considerations you might think. Could this be the wrong question? I mean, when you hire a nurse in primary care, in most cases, you don't say, will she or he pay for herself? You say, will this person add to the care in a way that we need, and can we afford it? And so if you think of behavioral health folks as people who will add to the care in the way you need and will bring in some money, just not as much as they're going to cost you at first, that's an important place to start. Starting out putting high productivity quotas on behavioral health folks tends to make for a more bifurcated system, because then they need to be in an office all the time seeing patients, and they're not helping the docs, and they're not consulting, and they're not being able to take warm handoffs, and they're not being able to do a lot of the things that may not be as billable in your situation. So you want to hold your horses with those. We'll get them to pay for themselves. All they'll have to do is so many patients a week or a day. And often people look at the number of patients seen a day in mature programs and say, well, we want that. We want our people to see 10 people a day or 9 people a day. And the answer is, well, if you have a mature program, that may be reasonable, but not now. It's not going to happen. And they need to develop clinically in order for that to be possible. Fee for service is a much harder environment in which to have the behavioral health pay for itself than in other kinds of payment situations. And the folks here who are involved in that know a lot of the list of other kinds of payment schemes. Clinical routines that bring more revenue may be unfamiliar to BHCs. I have sort of been talking about that, and to PCPs. They may very well not know how to involve someone and how it might be an interaction that could be billable and bring revenue. Behavioral health billing is challenging for your billing, coding, and compliance people. And they will be nervous. And so to the degree that those folks are risk averse is the degree to which it may be hard to go forward. And so many programs are hung up, not because they couldn't be billed in for what they're doing, but because the billing people had never sent out a bill like that. And they're very worried about doing it. May take a couple of years to get a full revenue stream. On the other hand, the Behavioral Health Service at Community Health of Central Washington, and I talked to the director of this month, with an FQHC with 7 sites, contributes $1 million a year above the cost of the Behavioral Health Service. So that's all in. That's salaries, that's fringe. The $1 million is about $600,000 in grants because they are a unique, well-known service. They have very well-known training in behavioral health. So I'm sure they have GPE grants and BWET grants and various things from HRSA and other places. But it's also $400,000 just in billings above their cost. You won't get there quickly, but it's a reasonable thing to be aware of that it can be done. Let's talk about models. So first, we'll talk about models generally. Models are sort of, the idea is that's how it's supposed to look. That's how the right way to do it. And we all wish we could look like that. Well, some of us don't, but models set a standard that is both useful and not useful, depending on your situation. So let's talk about behavioral health integration models. There are a couple that are best known. There are a whole bunch of different ones, but these are a couple that are best known. One is the collaborative care model. It involves usually a psychiatrist being clinical supervisor as well as prescribing consultant to the PCPs. It's based on substantial evidence, the impact program. And so it was designed, it's a disease-based program. In other words, in order to be in the COC group that are being served, I'm hearing somebody in the background blowing their nose. In order to be in that group, you have to have a specific diagnosis. Of the people who don't have that diagnosis are not in the group. They're not getting service under this model. All right, I unmuted myself, thank you. It has strong patient evidence for patients with that diagnosis, whatever mostly it's been for depression, sometimes for depression and chronic illness. cost evidence of savings for the patient served, but not for other patients. And then the person other than the psychiatrist involved is often called the care manager, though nowadays they're almost always licensed clinicians. That proved to be necessary over time as the program went on. The primary care behavioral health model is much more of a program-based model. In other words, behavioral health clinicians become part of the infrastructure of the program, of the site. It's a clinical heritage developed to increase access. It has strong evidence for satisfaction and evidence for clinical outcome, though it's harder to get the evidence because you're serving any diagnosis. So you have to look within the range of all these patients who are served in all these ways if you're trying to find evidence about a particular diagnosis. The cost evidence on the practice as a whole is very strong. And the person who is the behavioral health person is sometimes called the behavioral health consultant, sometimes called the behavioral health clinician. Both of these models really need strong psychiatry consultation on prescribing for the PCPs. That is not unique to COCM. They're tending to converge. The care manager model, the COCM model, after it's been in an organization for a while, tends to expand who they serve because people get frustrated that you're only serving people with depression. And I've got this lady here with anxiety who's every bit as disabled as your depressed people, and you're not serving her. Why not? Same thing with the PCBH model. Once you have behavioral health clinicians available around the practice so that they can be accessed quickly and easily, it's easy to have a program, start a new program for just a particular diagnosis. And I could tell you some good stories about how that's been done. Both models have very great variability in how they're implemented in model fidelity, and the variability does not correlate with how much they're true believers for their model. So people who are doing COCM may be doing it with very little of the outcome evidence that was in the original impact studies, but they'll be just as sure that they're doing the model. Same thing with PCBH. So this is how we look, really. And so I want to say that these models can be sort of North Star kind of ideas, things we're shooting for, things that can tell us what the next step might be given where we are. But we're going to improve in an iterative fashion almost always. I mean, if sometimes in very big implementations, there's been a big training effort to try and go to a particular model, but most big efforts have dealt with and allowed quite variable approaches. So the question that keeps coming back is, how can we serve our patients better? There needs to be continual learning experience or consultation. Going to run into problems over and over again, and they need somebody to help who knows what has been done in other settings that help to solve this issue. There need to have broad organization input on barriers and improvements. They all need to be talking about this, not just the behavioral health people, and keep studying what works. Go back and back and back and look at what you're doing right, because that's where you're going to get the energy and the vision to go forward. So what if you were to have a statewide program? Could do it. Some statewide programs come from the state health department, some from state health foundations that have funded them, some from federal grants. Most have offered voluntary participation, and in some settings have offered incentives for voluntary participation. In the Colorado setting, each practice that participated got $50,000 a year for the years of participation to support the whole effort of gathering the data that the program required. You need support from statewide leaders. The report on this program is over the signature of the lieutenant governor, and the governor talked about it all the time. It's a pretty good thing for politicians to have to talk about. You make the case for health equity and for taking action for folks in your state, and look at this program and how it's going to move things forward. It's a good thing for many politicians to talk about. It takes to have an active learning community with the group of the programs, but it also takes consultative support, boots on the ground, occasionally, not all the time, but occasionally, to help look at issues that come up. Webinars have not proven to do it in themselves. There's going to be an evaluation effort, I think, if you're going to spend that money. Fund the evaluation effort from the beginning, because how the evaluation is going to be set up impacts what people set up. And you need evaluators who know how to set up an evaluation program that highlights better care. And you start with the future of the workforce immediately, because you're going to need it. As you get going, you don't want to wait till you can't hire and then say, oh, we have to get somebody in the university or in the colleges to start turning out people for us. And I gave you two links. One is to a pathway for an alternative approach for developing behavioral health clinicians, growing them within your primary care site. And the other is to the GPE program at the University of Arkansas, clinical psych. GPE program is a specific HRSA program to train primary care behavioral health clinicians. And it looks to me like University of Arkansas turns out 5 a year. And what if that were 10 or 20? Once you have a structure, it's often a lot easier to enhance it. The payers can make this thing go so much faster. They can't do it alone, but they can really make it go faster, both with carrots and with removing barriers. Good example of a carrot program was the Massachusetts Primary Care Payment Reform program. It was a Medicaid program. And I was on the clinical committee that was advisory to the program. They ended up with an approach in which participating practices got, there were 3 possible levels. The first one required care coordination, and it required being able to report the data. And that took some doing in some places. And they got about $12 PMPM for that. They got a substantial bump for having a behavioral health clinician, 40 hours in the practice, and another bump if they had a psychiatrist on staff for 8 hours for a day a week. The Colorado innovation model, paid for the infrastructure to bring together the private payers and Medicaid to collaborate on payment models for that enhanced behavioral health. And that took a great deal of cooperation and a good many health policy and lawyer types to help get it done. The barriers. Here's some of the most difficult barriers. Perhaps the one way to guarantee it's not going to work is to have double copays for the same day. As soon as you say, the doctor says, Mr. Jones, I think you would be better served by my colleague, Ms. Smith here, who can help you with this stress and with the depressive symptoms that seem to be coming from your stress. And then they have to say, and it'll cost you another copay, it's a non-starter for so many people. And in some places, this has been fixed by legislation, Tennessee, for instance. In other places, it's been fixed because the payer said, okay, we get it. One copay for the services you get in your primary care practice on one visit, whatever those are. Demanding the same behavioral health in primary care as in mental health centers, where Medicaid often says, well, you have to do an 1.5 hour intake on every patient if we're going to fund it. So, well, that's not how you can do in primary care. You already know the patients. Those 1.5 hour intakes are for brand new people that nobody knows. You already got a social history, a medical history, that's all done. And so looking at the current problem and helping with an assessment is what the duty for the day, and behavior, that's needs to be supported. Accepting the behavioral health, the health and behavior codes. Health and behavior codes allow a behavioral health intervention for things like adherence for chronic illness, as opposed to having to have a mental health diagnosis. Failing to impanel behavioral health, new behavioral health clinicians. Companies often say, well, we have a panel and that's quite adequate. Well, it is quite adequate for the people who are looking for specialty services, but this is an additional 60 to 70% of your subscribers who are going to be, won't go there. I'm saying that wrong. 60% of your overall behavioral health need of your subscribers, not of your subscribers. Restricting payment to some kinds of behavioral health clinicians, you're going to be hurting for workforce. It will happen as you go. And so if you're not going to pay for licensed professional counselors or licensed mental health, marriage and family therapists, both of whom prove to be just as effective in primary care as social workers, as clinical social workers, and almost as effective as psychologists, because they all need the same kind of extra training in order to succeed in primary care. What you get for your leadership? Well, in Massachusetts, in primary care payment reform, Medicare saved 6.3% of the spend in the first year and 10% in the second year. Medicaid, did I say it that way? I don't want to say Medicare. Colorado, in the first 2 years of their program, saved $178 million for payers. So plus we have better equitable access and happier subscribers. Another thing was in JAMA just recently, said people who tried to go to mental health services and specialty care were very angry, or more likely to be angry, at their insurance provider, because they would say that's an inadequate network for us. We can't get what we want. People who got their care in primary care said, no, it's a fine network. It's okay. So maybe there would be a meeting. Maybe people could sit down, and I have the two kinds of meetings here. But however you would do it, sit down and have somebody from state health policy, someone from Medicaid, the private payers at the table. They need to be at the table. Major primary care providing organizations, state behavioral health integration experts, behavioral health access advocates, maybe someone who can talk about the HRSA programs that you might begin to access, and maybe somebody who could talk about behavioral health clinician training that you could access. So I have here my email. I'm happy to talk further with folks who are interested. I have the teamtelemed.net resource that Kim sent you. In that, you will find an integrated primary care visit for a patient with multiple burdens of illness. using a team approach. And but for someone who has not seen what an integrated primary care visit might look like, and the fact that it's on telemedicine is not necessarily the most interesting part. It's the language and the way that the MA hands off to the doc, and the doc hands off to the behavioral health clinician, and the behavioral health clinician's 18-minute interaction that makes a substantial difference in the person's likelihood of backsliding in their depression and their drinking, which means it reduces it substantially. And if someone said, well, you made a statement there that just can't be true, my evidence, the evidence for all the statements is in Patient-Centered Primary Care, my book. And I shouldn't be doing a commercial, but that's where it is. So let me stop sharing and ask Kim to tell me what I should be answering.
Thank you for that wonderful information, Dr. Blount. We do have a couple of questions. This is a multi-part question, so I'll just start with the first part, which is, do you have some practical steps on integrating behavioral health with physical health in a state like Arkansas? And then Arkansas is a low maturity with the most challenging medical and psychosocial conditions and lower than average access gaps, with minimal co-locations, same-day referrals, or coordinations. What are the first things first, or the most mission critical things to get it started and to begin to build momentum? And then what are some examples of models, successful models?
Okay, well, I hope that was written early in my presentation, because that's sort of what I thought I was doing. That
Yeah.
The presentation today was specifically for what would you do to start. Maybe you would have a meeting. Maybe you would see where the energy was, because I listed all these people who might come to that meeting, but you don't want to not start because someone from one of those groups won't come. You want to have to see where the energy is and to support the energy where you find it. One of the temptations in a situation of new implementation is often, let's build one great practice. We'll just throw all our energy and focus in there, and we'll have this shining city on the hill kind of thing going. And then other people will reproduce that. And I suggest that that's not as good an approach. We already have one shining city on the hill in integration, and that's Cherokee Health Systems in Tennessee. And one of the things that I find as I talk to people about, so this is what they do at Cherokee, is people say, well, we're not Cherokee. We have our own situation here. We have our own needs. We have different patients. And so the fact that this is what you're supposed to do and you should go there is not attractive to a lot of folks who feel like they're working hard where they are. And you're coming in and saying you're not doing it right. That's not a helpful message often. So doing it broadly and then growing the depth, as opposed to doing it deeply and then trying to broaden it out, makes more sense, I think. When I said find out what's going right and focus on it, you can do that on a statewide level too. That you go around and whatever you do, tell a story. Don't just give the data. Data makes it credible, but the story helps people know what to do. Data doesn't tell them what to do. So when I first was the behavioral health clinician in a practice in family medicine, I used to put out a newsletter every couple of months. And I would say, well, we saw these many patients, and these are the kind of diagnoses we tended to be working with and so forth. But I would also tell one story. And the clinical story would be something that went very well, often with a situation that the providers would not have thought I would have dealt with. So person with irritable bowel syndrome worked with me, got much better, was able to go out and basically get her life back. And when I told that story, then I got 3 more referrals for irritable bowel syndrome within the next couple of weeks. Nobody thought, oh, really, you can do that? So telling the story of what's working, and people will particularly love it if you know that it's in this little town and this little practice where they're doing this or that. And you don't have to say they have it all right, but just here's how it worked on this story. And as other people see that, people start to think, well, integration's actually getting going in Arkansas. Yeah, you would like people to identify with integration as something that that characterizes Arkansas to the degree that it's possible, as opposed to this is strange and new, and that's not what we do here in Arkansas. I hope that's a start, at least, of an answer. And then, I mean, the little subroutines that make a difference, I've got a million of those. Let me give you one example. A warm handoff. In other words, where the physician says, here, this is my colleague, I'd like to get her involved in your care. If you say it as if there are 2 kinds of care, you say, Mrs. Schwartz, I think you have depression, and so I've brought in my psychologist colleague to treat your depression. That is much less likely to work than if you say, Mrs. Jones, I know you're struggling with a great deal of stress, and it makes you have a hard time getting up in the morning. And I know you're putting on weight, and I know that you just don't do the kinds of things that you used to do that you enjoyed. And so I have a colleague, Mrs. Smith, who is particularly good at helping people cope with stress. Can I bring her in? At this point now, it's going to be fine. And they're likely to make the connection. And it will be easier once there's a connection and once she's feeling better to talk about depression. And it's also much easier to make a referral to longer-term care. Mrs. Jones is much more likely to go or to long-term care after she's interacted with behavioral health and primary care than if it's just a direct referral. If you say, oh, this is too serious, we can't do anything with this. Well, no, you can't do hour-a-week long-term therapy with this person. And if you think that's what they need, it still might be better to start with your behavioral health clinician, because guess what? It doesn't always require that. And people get they make a little step in the right direction. They feel better. They often say, well, that's good. I'll come back when I need you. And so we had a lot of people who came back and back and back, once every couple of years for what we often used to call a tune-up. And then they would feel better and go back to their lives. The idea is that you're living your life, and I'm helping you with it, and helping your doctor take care of you for leading your life, as opposed to, I'm going to treat you with depth therapy, and then you'll be made better for good, which is not how it works in the real world. Next question.
Sure. Next question is, do you have any suggestions on how practices can afford to get started, especially when they're maybe having financial shortages and they want to start this type of program, but how do they get started as far as making this affordable? And
yeah, well, one of the reasons for appealing on a statewide level is that at the very end of the chain, in other words, somebody's practice in this little town in Arkansas, you don't have much leverage. And so it's hard. And I don't know the conditions in terms of the regulations and how responsive payers are and so forth in Arkansas, much less in that little corner. But if you get leadership from the center, it makes a lot of difference. The other thing is, I said this before, if you go in saying this has to pay for itself from the jump, don't start. It's not going to happen. And so you don't want people being disappointed. I mean, if you do the numbers of what you can get for a visit, a half-hour visit, and you do the numbers of how many visits some mature program does, and you say, whoa, this works. This really works. We can pay her salary and fringes. This is going to be fine. And it isn't going to be fine yet. She's going to work up very slowly to doing it. The docs have to learn to be part of the team. It doesn't just happen having the behavioral health person there. So having some kind of bridge to get started can be very important. And often practices can find some money to do that. But it's really not helpful where people do the math and think it's going to work and then are disappointed and then are putting pressure on the BHC saying, well, we thought you were going to pay for yourself, but now look, you still owe us your fringes. So, and having some kind of consultative back place to go in the state to solve problems. So that people have specific questions, that question doesn't stop the forward momentum. They can go talk to someone who's done it before, and either in Arkansas or more generally. Others, we got another couple of minutes.
Dr. Blount, I was going to say, in reference to what you said earlier, recently our team of BHC, we have 5 BHCs in one of our systems, and we ran some of our numbers, and of 3,900 patient visits, the average number of visits per patient was 1.5. And this was a whole range of complaints and issues. So our data, this has been over the last 4 years with our CPC Plus initiative that was paying for the BHC, so they weren't having to worry about paying for their overhead. But and we also had some of the same data you referred to in terms of decreasing the PHQ-9s, the depression, the complaints, and patients felt like they got what they needed in 1.5 visits. Yeah,
when I went from being, I was in specialty mental health for 20 years before I went into primary care, and my number of visits cut in half before I changed anything, just because I was seeing people earlier in the process. If you have been in specialty mental health and you know how therapy tends to evolve there, and you get into primary care, the first thing you notice is these people get better fast. They look just as dysfunctional or struggling, I guess is a better word, at the beginning, but don't they just take off? And so, because by the time this person I'm seeing now got to specialty mental health, meaning maybe they were one of the 25% that gets there, it's going to be 4 or 5 years down the line before somebody says, oh, I'm so completely struggling that I'll go to specialty care. So we catch everybody earlier in the process. Same thing with alcohol or drugs. We're catching them much earlier and making a difference much earlier. And for instance, I worked with a lot of people around drinking who were drinking amounts that and someone in the substance abuse world would have said were insignificant. Well, they might be insignificant in relation to who's walking in your door, but they're significant in relation, for instance, to his diabetes. 2 beers a night is a real problem in diabetes. And so we're talking about substances all the time as part of the work we're doing.
Okay. I was going to say,
okay.
thank you so much, Dr. Blount, for all of your information today. We know it's 9:01 and we want to be respectful of everyone's time. Thank you for coming today, Dr. Blount. Thank you for sharing all of this wonderful information. As he said, there is a link that I sent out on the invite that has an example of a integrated behavioral health visit in primary care, and it'll be fantastic if you can check that out. I think that it'll be very, very helpful as we start to wrap our minds around how do we do primary care in a telehealth setting. And so I know we get that question a lot. Let us know if you have any questions. We will be posting this recording on our website, and we thank you so much for your participation, and we'll see you back in December.
All right. Thank you.
Take care. Bye-bye.